Good evening for the people in India and good afternoon for the people in Europe. This is my first time participation in the APVIC and also my first time participation in the Ironman contest. I'd like to thank Dr. Khanna for the nice invitation. Okay. This is a case of 42-year-old lady from a poor African country. She has been complaining of bilateral shoulder and arm pain for more than 10 years. She moved to UAE about 6 years ago, and she was diagnosed with Takayasu arthritis according to a duplex study, and she was started on steroid and aspirin. Luckily, her husband got a job last year at a government institution that offered him a good health insurance for him and his family. This insurance gives coverage for pre-existing condition. So she was evaluated in another center and a CT angio was done and showed bilateral occlusion of her subclavian arteries. A diagnostic angiogram was done at another center by an interventional radiologist who documented those occlusion, and I will show you those angiograms just shortly. She was told that nothing can be done, and she was advised to continue on medical therapy with her rheumatologist. She was seen in 5 another centers across the UAE with the same recommendations. So this is the angiogram. It's not a good quality angiogram, but this is the angiogram of her right subclavian artery. And you see that the right subclavian artery is totally occluded after the origin of the vertebral. And this is the right carotid, but there is no arteries to be seen distal to the vertebral, and there is a lot of bridging collaterals. I'll show you a better angiogram later. This is just a fixed picture to explain that this is her right carotid and this is her right vertebral, and there is no arteries beyond that. There is some collaterals around the scapula here. And this is her angiogram of the right carotid, and thank God she did not have any obstruction or stenosis in the carotid artery on the right side. And also on the left side, this is her left carotid, and also it's clear, it's patent, and the intracranial branches are fine. So the left subclavian artery showed again total occlusion immediately or at the origin of her left vertebral, and you can see that on another view. So this is her diagnostic angiogram, which was done by interventional radiologists in another centers. Her symptoms got worse with shoulder pain even at rest. She was unable to bathe herself or comb her hair. Her young daughter really became so sad because her mother wasn't able to do her hair for school in the morning. She heard about our free second opinion consultation at our center, and she was referred by the reception to the vascular surgeon, who finally asked me to see her for my opinion whether I can do any intervention for her. So just with her symptoms, and she kept pushing and asking, let's get the benefit of this insurance coverage. I brought her to the cath lab to re-evaluate the things. So I wanted to start with the left subclavian intervention, but again, before starting the intervention for the left subclavian, I got a good picture of the right subclavian, and you see that again, that there is really a lot of bridging collateral. It's like a labyrinth. There is no way you can detect where this right subclavian artery is going. And this is another view, and you can see that. And I extended the view a little bit to the humerus area, brachial area, and you cannot see any distal filling. But just I wanted to start with the left bit because it looks to me a little bit easier. So to give her some hope. So this is another view of her left subclavian, and I engaged that with a guiding catheter of multi-purpose And with using my coronary equipment, since I'm a cardiologist, I use a coronary wire supported with a coronary balloon. I was able to cross the area of total occlusion, and I hope that you can see that. This is the wire went almost beyond, and we crossed the area of total occlusion. And I did the pre-dilation, and this is the angiogram after pre-dilation. And you see again, there is another area of total occlusion, a lot of bridging collaterals, and you cannot decide where to go. But the idea is always at the bridging collateral, try to cross blindly and dig in this area to open the total occlusion. So you see now my wire here, it's already across an area of total occlusion around those 3 bridging collaterals. So I cross that. The way is that I make a loop with the wire and keep pushing the wire with the support of the balloon. And again, I crossed this area, but again, you see the wire went into another bridging collateral, because this is not the way of the brachial artery or the axillary artery. It went across the humerus. So, but anyway, I accepted that, and I did some dilation. And with this balloon, you see there is a lot of fibrosis. The balloon hardly can open, and I had to use a lot of high blood pressure. But here also there is the watermelon effect. Whenever I'm inflating the balloon is slipping in and out, until finally I was able to do the full pre-dilation with a 3 millimeter coronary balloon. And after that, I got better result. After I advanced the guiding catheter, you see the guiding catheter here advanced, and you see on this angiogram that again I'm stopped at bridging collateral here, and here is the brachial artery. There is another area of total occlusion, and again I have to dig blindly between those bridging collateral to reach the brachial artery. Actually, there were another cardiologist watching me from behind in the control room, and he said, that's enough. You opened a lot, and there is a lot of collateral here around the humerus. You can stop. But I decided to continue. And this is the area of total occlusion that we had to cross. So finally, I was able to pull the wire and make a loop and redirect the wire. And you see that, hopefully you can see that this is the area now. There is some staining at the intersection of those bridging collateral. I make the loop now with the wire, and this wire now gets support of the balloon, and the balloon now supporting the loop at the area of total occlusion. And now again, I entered the another bridging collateral, and now crossed the area of total occlusion blindly with this loop. And you see now the loop will continue further and further until we get the crossing. Now it's advancing, and it should go for more with some pushing from the balloon and some support until we can cross. And this is really fibrosed area, which is very hard to cross, but we need to cross that blindly in order to open the full lumen. So finally, it did advance a little bit with the support of the balloon. It did move forward and another bit forward, until we enter now further. We enter now, hopefully, we enter now the brachial artery. Now with that, this is the successful, we did further pre-dilation with a larger balloon. And with that, we got very nice result without a dissection. And before stenting the area, I went just prophylactically, you see that, through the vertebral artery and dilated the ostium of the vertebral artery to prevent any plaque shift, and did the stenting. And this is the final result and the final angiogram for the left subclavian. She did very well, and she kept pushing me, please try to do the right. And you know, the right is very difficult, but she kept pushing until after 2 months, I decided to accept the risk and push for the opening the other side. So this is the another just reminder of the bad angiogram from the subclavian, and I don't think I can cross it blindly from this anterograde from the femoral axis. So I decided to go retrograde. So there were no radial arteries. So I went through ultrasound guided the axis through the radial artery until I found the axis from the radial artery. You see here the wire is entering. Sorry, I'll go back. So this is the wire entering the radial artery from ultrasound guided, and you see the wire reaches the humerus, and that I put a diagnostic catheter, and this is the area of total occlusion. Again, a lot of bridging collateral around the humerus. So this is the DSA showing that we have to go through this bridging collateral to open, and the same with my coronary wire with support of the loop and the balloon. I was able to cross, and this is the crossing. And finally, the balloon stopped and the loop stopped without any further advancement at this area. And I did the angiogram from the contralateral, from the femoral axis, and I hardly can see. That's mean the wire is stopping here. And what's the problem? I don't think we can advance more. And you know, this is the pathogenesis of Takayasu disease. There may be an aneurysm formation. So probably the wire is stuck in the aneurysm. So anyway, I dilated with the coronary balloon, and dilated further and did an angiogram. And look at the angiogram, although there is no dissection and good result, but there is a staining here and the wire is stopping. So that's mean this is most likely an aneurysm that stuck the wire, and the guiding catheter is stuck. Here is the angiogram from the other side. You see, I can't see any further dye anterograde. So we have to do kissing catheter in order to cross. And it is really like inserting a string through a needle. There is only one area you can cross it. And this is another angiogram showing how bad is the area and how can you engage. So finally, this is the angiogram. I diverted the catheter, which is from the radial artery upward, and you see that there is an area now of aneurysm, and between those two areas, there is only tiny thing that we can go through, and this is, we have to go anterograde. So with that, I spent around 5 minutes on fluoro trying to insert this tiny wire through this tiny area. And that's, we need to see that it is recorded on fluorosave. And you see, this is the wire, and I'm going anterograde, and with the support of tiny coronary balloon, just trying to go through this area and not to perforate the aneurysm. So I pulled back the wire, and the wire is pulled back now and need to be redirected slowly to enter. And with this redirection, it did enter the distal lumen, if you can see that. And how bad is that? You see, I went with this 1 balloon, 2 millimeter balloon is not opening, 5 millimeter balloon is not opening. With that, more balloon, I'm inflating, and the balloon got ruptured. So with that, this area is so fibrous and cannot be dilated. So the only thing that was to me, the only option is to use really a cutting balloon. And just remember, I'm using 5 French guiding catheter from the femoral artery for anterograde crossing. And a cutting balloon doesn't go into 5 French catheters. So again, I have to guide myself and recross from the radial axis again to the subclavian artery. So finally, I was able to cross and put a cutting balloon, and this is the cutting balloon. And with high pressure with the cutting balloon, I was able to dilate finally, and then did further dilation. And you see with the stenting, this is the aneurysm got clear. That's where we stuck. So I put another stent, and this is the final angiogram to opening the other and we got a very nice result. And this is the distal runoff down to the arm. And just, I did not forget at that time to recheck my previous side on the left subclavian, which I opened about 2 months ago, and is patent together with the vertebral artery. Just at the end, I know this is Iron Man competition, but just remember what I mean by Iron Man. Iron mean Fe and man mean male. So it is like a female. Just consider me as soft as a female. Thank you very much.
Thank you very much, Dr. Kadro. If Dr. Reed or somebody, the judges have some question, 1 or 2 quick questions, it's fine. That's your certificate for qualifying into Ironman, and this year we have 5 qualifiers, so 1 from each country. So you are from UAE, and we have Dr. Ivo Petrov from Bulgaria, we have Dr. Zoltan Ruza from Hungary, and we have Dr. Girish Varavadikar from India, and Dr. Saiful from Malaysia. So,
Dr. Kadro, can I just start by congratulating you? I thought that was fabulous. And I do have 1 or 2 questions for you. I wanted to comment to you that I admired your, what I call coronary techniques of small wires and small balloons to begin to get through a very difficult problem. So congratulations about managing to do this. It certainly fulfills the Ironman criteria. 3 questions. What would your long-term strategy be for this patient in terms of medical treatment and surveillance, perhaps? What would your advice be to others in managing this arteritis? And what are you going to do in the long term about the aneurysmal change in the right subclavian artery?
Okay. Thank you very much. All of them really are a great question. Now, from the medical point of view, I'm not a rheumatologist, but I'll discuss the situation with the rheumatologist. According to the rheumatologist, once the patient reaches this degree of fibrosis, I don't think she'll get benefit from steroid therapy or immunosuppression therapy. So just would continue on a medical management, control the risk factor, keep her on aspirin, keep her on statin, and just to watch her for any deterioration. Usually, as I told you, this is fibrosed area. It's not atherosclerotic. So once the fibrosed area you get dilated, there is only chance of recoil, but the recoil, according to what I read, is around 10%. So if there is any recoil, we try to redilate. Now, for the aneurysmal formation, this was a surprise for me, and at that time there were no point to put a cover stent with all those tiny equipment that I'm working with, 5 French and 6 French guiding catheter. So I decided just to cover with a stent, but usually those stents may get thrombosed, and I do have a follow-up on this patient with just ultrasound, with showing good patency in all the arteries, including the brachial, the radial, and the ulnar. The third question was
it was really how you long-term might look after the aneurysmal change on the right side. Just as yeah. I guess part of my second question is the surveillance for this young woman, just to maybe watch out a little bit in case that becomes a problem.
Yeah. Well, there are two things. I'm treating her because she was really symptomatic. Those patients don't present with acute limb ischemia. I haven't heard or read anything. I have some good experience with Takayasu. I've done more than 15 cases, but they don't present with critical limb ischemia, hand ischemia, or necrosis of the finger. They present with really symptoms of ischemia of the shoulder and the hand, especially when they do some work with the hand. So as long as the patient is adequately treated for her symptom, that she's able now to bathe her hair and take care of her daughter, that should be fine. But I'll keep looking for any other symptoms, like whether there is some arm claudication or jaw claudication. But thank God her carotid are okay compared to I had another patient who had really significant stenosis in her external carotid, and she had significant jaw claudication that she was unable to eat one apple completely because of this problem.
Wow. Well, congratulations. It's a great opening to the Ironman session.
Okay, good. Thank you.
So now we have the next speaker, next contestant. It is Dr. Ivo Pedro, and if I'm not wrong, he was the Ironman of the last year. And let's see what he has this year.